The surgical outcomes on this patient, I think, is what we would have expected. When we see a patient receive neoadjuvant therapy with chemo and the dual HER2 targeted agents, the expectation of a complete pathologic CR is upwards of 50%. So looking at this patient at the time of surgery, she had only a small residual burden of about 4 millimeters, but her lymph nodes were all negative, and that certainly, I think, plays into the highest outcomes and prognostic feature for the patient in having lymph node negative disease. You know, we're trying to incorporate how to make risk predictions of patients in terms of recurrence based on the presence or absence of residual disease after neoadjuvant therapy. If we look at this patient's 4 millimeter burden, she would likely fall into a residual cancer burden of 1 that has an excellent prognosis and really patterns after those patients that have a complete pathologic CR. So I think that's an excellent finding for the patient, that she has cleared her lymph nodes that were not only abnormal by imaging, but also documented to have metastatic disease. And so I still think her prognosis is excellent based on the fact that we were able to eradicate the metastatic disease in the lymph nodes and have only this microscopic burden left in the breast. The recommended adjuvant therapy for a HER2 positive patient who's undergone neoadjuvant therapy, the standard guidelines really look at Herceptin, and that's where the data has been. When we look at the neoadjuvant trials, they gave the dual HER2 therapy up front, but at that time the trials completed the adjuvant component of their therapy post-surgery with single agent Herceptin. My approach to this patient and looking at pertuzumab and the indications for pertuzumab in a high-risk patient from the adjuvant setting and the affinity data, I clearly think that this patient is a high-risk patient that had documented lymph node positive disease. And I would recommend the addition of Perjeta or pertuzumab to Herceptin in the adjuvant setting. That would be typically what I would talk to the patient about in the absence of any prohibitive toxicity. When I look at the patient and try to figure out my adjuvant treatment strategies, I would say for the most part, anyone that I've treated neoadjuvantly and also tolerated the dual HER2 therapy, I have the tendency to continue that in the adjuvant setting. I do think if you had a lower risk cancer, maybe just 2 centimeters, nodes were noted to be negative, that you could continue, and that would be definitely within the guidelines as well of just a Herceptin-based regimen. But for the most part, I think patients who I treat with neoadjuvant dual HER2 therapy and we're not facing an intolerance, that I would continue that after surgery in the adjuvant fashion for the patient. The dual HER2 targeted therapies, I think, have offered the patients the best overall disease-free survival and overall survival. And we can look at both the neoadjuvant trials and really extrapolate, in this case, from the affinity trial as well, that showed the addition of pertuzumab to HER2 targeted therapy in the adjuvant setting, which I think is a year of therapy. So if I looked at my practice preference of treating the patient both in the neoadjuvant and adjuvant setting, I think I'm giving that patient the best chance for curability. And when we look at the HER2 therapy as a whole, we know that it's decreased the disease-free survival by 40%, the risk of recurrence. And so I really would want to offer that for that patient. In the adjuvant trial for the affinity, we noted that it had an absolute disease-free benefit for those patients and putting their disease-free survival in the 90% plus range. And so I really roll out all these treatment options for the patient to ensure that they're getting their best chance for curability.